name is Brianna. I'm going to go ahead and begin with the presentation. We start with to draw with. Let's get started. Our first condition, return our slide, is cholecystitis. I already know what the disorder is, so some of them I don't say it. I say gallbladder inflammation disorder. Okay. In the presentation link, the box that's under there, you got my post priority tips, and you can just type them inside of this box on the title page of the disorder. Excuse me. So let's get started again. So gallbladder inflammation is inflammation of the gallbladder wall, okay? If you don't know how to pronounce these words, you already know this order. It's called how it is. You're reading NCLEX questions, don't make it hard on yourself, okay? So it's inflammation of the gallbladder wall. Inflammation is often caused by gallstones. So what happens is, I'm gonna draw a rough thing and everything. So it's good to have an artistic ability here. So I'm gonna draw the gallbladder. I'm gonna draw the duct that goes to the liver and connects to the pancreas. Biliary bile duct, and then here's the liver over here. No, something like that. Here's my gallbladder. The liver drains the gallbladder, the bowel, drains the bowel down into the gallbladder, and when we eat fat, it stimulates, starts with the spasm, and the bowel comes down to the duodenum to digest our fats. Well, when gallstones, or they look like this, they look like this, they get trapped inside here or here. Well, not necessarily in the pancreas, but this pancreatic duct here gets stuck there, can cause pancreatitis. The bowel that gets squeezed out into here can't get free, so it backs up and it causes congestion and inhibits the liver from being able to function. If we do not treat this, it can perforate, meaning all that bile stuff that's in there gets leaked into the perineal cavity. It's a medical emergency, and we don't want bacteria and all that stuff. It's inflamed, so there's infection involved. So if it perforates, that content comes out and causes peritonitis. And the complications to all of these disorders, well, the inflammatory bowel disorders leads to peritonitis. We're going to talk about those complications. Let's get into that slide. Inflammation is caused by gallstones obstructing the cystic and common bile ducts. Bile flows from the gallbladder to the duodenum. Okay, bile backs up, causing inflammation. We talked about that. Gallbladder inflammation is the presence of stones in the gallbladder related to the participation of either bile or cholesterol into stones. Bile is made by the liver and stored in the gallbladder, and is used to break down fat and release in the duodenum. Bowel blockage can cause pancreatitis, gallbladder rupture, leading to peritonitis. Everything I just said is on this slide, so without having even to read it. So I break it down so that you don't have to dig through all those books to understand what this is. Okay, so back to the presentation. So we know what gallbladder inflammation or cholecystitis is. Okay, so when we have this, it's going to be up here. It's going to have some pain in the right upper quadrant. So when we're doing our abdominal assessment, there might be some tenderness there. Okay, when you compare patient to. Okay, so what causes the gallbladder to become inflamed? We said gallstones. Okay, gallstones can be made of bile and cholesterol. So what is bile? When red blood cells die, because they only have 120 days life cycle for adults and 70 days for kids. Okay, so when my blood cells break down, when that byproduct of my dead blood cell being broken down by the body creates bilirubin and a heme component. It breaks it all the way down, and it gets recycled, and what's not needed anymore gets turned into bile. Okay, so you want to really associate your bilirubin with your bile. Okay, so if this is how you have to do it. Okay, so if bilirubin is used to make bile, because it's turned into bile once it hits the liver and it's processed, it turns into that. So if bilirubin is high, that means my gallbladder is not, or so my liver is not functioning, or something's going on in that area of things to where bile is bilirubin is piling up high. So you can check your bilirubin levels to help you associate with bile. Okay, so if that builds up, it can cause stagnation of your content. So if I have this disorder, I want to consume low fat. A low fat diet. Why would I want a low fat diet? Well, when we eat fat, it stimulates the gallbladder to spasm to release the bile. So upon your intake of fat, that happens. So I want a low fat diet, so it won't be spasming, hurting when it's inflamed if I eat. So some foods like diets, you also want it rich in HDL. This helps eat away the plaques that's on, or the bad stuff in your vessels, okay? You want that seafood, nuts, olive oil. So change the grease to olive oil when you can. Participate in regular exercise. What does exercise do? It just keeps the blood flowing good and smooth. It also helps create more HDLs to help with breaking down of stuff in your vessels that's not supposed to be there, okay? And no smoking. Now, here are your risks. So females, don't know why, there's the estrogen therapy, genetics, obesity, Crohn's disease. Now, when we come across another GI disorder, we're going to go and talk about it. So, how would Crohn's disease cause cholecystitis? Well, Crohn's can happen on any part of the GI tract from the mouth down to the anus, versus ulcerative colitis, it's going to only station itself from the anus to the colon, the large intestines, not the small. So, when Crohn's hit, it's going to penetrate all the layers of the intestine or wherever it's going to be. And so, Crohn's is going to cause dead tissue if it keeps, So what's happening there are bacteria. It's able to leak into the intestinal cell due to genetics, the lining of the GI tract, those cells, they're more spaced out than they should. And we have a submucosal layer and a mucosal layer that has bacteria on those naturally to help break down our food and stuff like that. So when they're spaced out, that bacteria can seep in, and this triggers our immune system to react, and it does an overboard response, and it causes a destruction of everything. They release the cytokines, and those little small, it's like little acid bugs just eating away at that tissue. And we're going to talk about how we treat that. We hear about some disease. People say, well, how do I treat that? How do I treat that? Well, we're going to talk about we're on gallbladder right now. So with that scarring of the tissue can cause, look at what the duodenum is. It can part of it is connected with that pancreatic duct, that biliary tract. It's going to secrete its content into the duodenum, which is part of the GI tract. And Crohn's can happen anywhere. So if you have Crohn's and it's happening right there, that can cause bowel buildup because peristalsis is not happening either. It's not moving that area, so stuff is just staying there. So when it gets squeezed out, it's just there. You know what I mean? In a sense of like that. So this can cause gallstones. It can cause stenosis of that duct, and bowel can't drain. This can lead to jaundice. So when we're dealing with gallbladder issues, when it's complicated, you're going to have the yellowing of the eyes, yellowing of the skin, itching. It's going to affect the liver because the liver is draining its content inside of this storage, and if it can't, it's going to occlude or build up in its tissue itself, and this is going to impair the liver function. Now we got to worry about our bleeding, our protein, ammonia, so gallbladder, cholecystitis, the complication, if it's not treated, can lead to severe things. So let's continue talking about our risk. If you eat a low-calorie, I'm not really sure about that one, but maybe malnutrition, and I'm not sure about that one. Liquid protein diet, if you have a liquid, we just getting things started. A liquid protein diet can cause gallbladder inflammation. How is that? Well, we got to look at pancreatitis because having that can also cause this. When enzymes that's ready for duodenal digestion activates inside the pancreas, it can that duct occlusion can cause bowel obstruction. And so a liquid protein diet, if you just eat all protein, is going to cause stimulation of that. It's that way. Rapid weight loss. These are just risks. You know what I'm saying? If you have it, Native American, you can see why you being a risk can cause it. You being like the estrogen therapy. Estrogen it dries up things, so it can, you can just understand why it would be a risk. Okay, so these are risks. But while no smoking impairs the function of the lining. Participate in regular exercise. That's to help with, I guess, muscle activity. Okay. Sorry. This stuff that you want to do if you have this. You want to prevent obesity because being obese can cause this too. When your pancreas have to work a lot, it can become inflamed. So it's a lot of stuff you have to group together when you are studying so that you can put it all together. Okay. You talked about obesity already. Genetics, talking about being a female. Okay, let's finish. So this is what you will find if someone will come in. I'm having this sharp pain in the right upper quadrant, or right hand upper quadrant, and that's where your gallbladder is, and it radiates to the. It actually radiates to the left shoulder. Okay, and I'm going to. It's not the. It's the left shoulder, okay, because the pancreas extends over here, and it radiates to the left shoulder. So, okay, it is to the right shoulder. I have my book, so trust me on that. On all of it, because I'm not. I didn't. That's stuff. So it will radiate to the right shoulder because it's that. I was thinking about pancreatitis, and pancreatitis is going to radiate to the left. You would think it'd be the right, but pancreatitis is the left because it's a bigger organ and it's kind of like in the middle. So, boom. Now with the gallbladder, which is stationed under the liver, it's going to be right upper quadrant, it radiates to the right shoulder. It's closest to the right shoulder, so it makes sense, okay? Pain with deep inspiration, you have to think about the diaphragm. And when you breathe in and out, it causes that inflamed, hurt area to move. You know how you don't want to press anything when it's a bruise, you get a bruise or something, you don't want to press on it? Well, it's just like that. You're doing that too when you're breathing up and down. You just have to put yourself in your disorder's shoes. Act as if it's happening to you and make it make sense. When you not have a breathing problem, if you was having some pain right here and your lung right there, when you breathe up down, it's hurt. When you're hurt, yeah. So intense pain, you're gonna, pain is going to increase the heart rate. You're gonna be sweating, you're gonna be pallor, because it's okay. The pain is gonna cause you to intake more oxygen, and when you're under, pain, it takes more of that. So you might be a little pale because you really can't breathe like you want to because it's hurting. You know what I'm saying? So you might not be getting oxygen that you need to compensate for your pain. Rebound tenderness, like when provider touches it. Only the provider does this with cholecystitis. Okay, nobody else does it. So when they palpate and they assume that it's a gallbladder inflammation, the doctor is doing it, palpates it, and it's going to be rebound tenderness. So it's going to be like that. Rebound. Okay, so I'm sorry. Dyspepsia. Okay, that is some heartburn. That's heartburn. And then irritation is having burping and flatulence is gas. So okay, dyspepsia is just upper stomach pain. I thought it meant something else. Sorry. Then you're gonna have a fever. Anytime you have inflammation, you're gonna have a fever. You have to think about the things that's associated. You're gonna have swelling, edema, swelling, which is edema. Sorry, pain, heat, which is for the fever, redness, and tenderness. So when you have those things happening to an organ, it's going to have fever because the heat is to try to kill off the bacteria. And in gallbladder inflammation, it's the bowel is causing it to be inflamed. Okay, I'm going to go see if it's if there's any kind of bacteria associated. I mean, a bacteria can inflame your gallbladder. Traumas. There are usual ways of inflaming tissue. But the one that's commonly causative of this is gallstones. Okay, so we talked about jaundice already. So if I can't get my bowel out, bowel's going to backflow into the liver, and it's going to crowd out or occlude or clog liver cells. Liver can't function. Now I'm at risk for ammonia buildup, which is going to cause flapping of my hands. The LOC changes. You just got to throw it all in there. It's a lot to learn and a lot to know. So, it's good to have something to just play in your ear to remind you of it because it's so much. To prevent you having to keep digging through that book every time, just play the video and, oh yeah, okay, that makes sense. Okay, next. Now we're going to find the lab. So if I'm hurting, I'm a patient, I'm hurt, and they said, we're going to do some labs. So I'll have an increase in white blood cells. So anytime there's inflammation, white blood cell count is going to be increased. Okay, so we discussed that the bowel causes inflammation. Now let's go further into that. So let's say you have this fluid built up in a circle, and it's to the point to where the pressure of the fluid is hurting the element or whatever. Okay, that's what's happening with the gallbladder. Okay, that pressure is hurting, and it's what's causing inflammation. But anytime there's injury to a tissue or cell in our body, our white blood cells is going to be activated. So if my organ is inflamed due to this pressure, the white blood cells, or the policemen of the body, in a sense, are going to come and try to make sure there's no bacteria. Okay, and you want to know what else? Is, which is why it's a good thing in a sense. If I do not correct my condition, I can burst open my gallbladder internally, and I can't get to it. So all that bile that was stuck in there is seeped out into the peritoneal cavity, and this is a emergency and cause shock. Okay, death too. So that's why we want to catch it. So if you have any symptoms, go ahead and get checked out. When you do the labs, increase white blood cells because of the inflammation. Direct and indirect bilirubin can increase. Well, of course, the storage is malfunction, so it's just there. And like in my case, these are liver enzymes are going to be increased because that buildup is going to damage some liver cells too. If it damages the gallbladder cell, you just got to know it's going to damage that liver cell and so on. So ALT, AST, LDH, those are associated with the liver, so they're going to be elevated whenever there's liver issues. Okay, so amylase and lipase will be increased too with pancreatic involvement. If the pancreas, as we talked about earlier, is a cause of my gallbladder being inflamed, those enzymes that it secretes is going to be up because those enzymes is what's causing the pancreatitis. That duct is blocking them from being able to get out, so they're activating inside the organ. And so if so gallstones are caused by pancreatitis too, but if it's pancreatitis primarily, those enzymes are activating before they get to the duodenum. So when they inflame the pancreatic tissue, it blocks off that duct, and bile can't get out when fat is inside or the stomach. And this is going to lead to liver backflow dysfunction, jaundice. And our other main thing to look at are ammonia levels. Liver is down; it can't break down the protein into ammonia, and the ones that it did break down, it's still circulating. The other liver cells are still making some ammonia, but its ability to filter it out fast is impaired, or the way it's impaired. So ammonia levels can build up and cause LOC changes. We are talking about that. Okay, so to diagnose if I have a problem with my gallbladder, I do not want to have a problem with my gallbladder. Okay, so this is what they can do to visualize it. So ultrasound, see for gallstones, an abdominal X-ray to see an enlarged gallbladder, which it will be because it's inflamed, just the swelling because it's inflamed. Hepatobiliary scan to check for stones too in that biliary duct area. Endoscopic retrograde. Okay, this is to look in. This is where they go in through the esophagus, through the duodenum to visualize the biliary duct to remove. They can remove stones here too. Okay, so we're going to administer pain medicine because this is going to hurt. Next slide. We're going to give some opioids, some morphine because they're going to be hurting. Bile acid, that is what's going to help combat with okay, so the bile acid is going to dissolve the cholesterol-based bile. Okay, so cholesterol-based bile, which causes gallstones, needs to be broken down. We don't have to do the surgery if we can get them to take medicine to break down those stones. Okay, or we can move it out via these procedures here. We talked about the removal during surgery, okay? And the other one is when they're going to deliver shockwaves, shockwaves to try to shake those stones loose. A drainage tube we use to drain the bile after surgery. You just gotta know after inflammation of that organ, that poor little organ, and you know how it looks. It's not going to be functioning the way it should be when you come out of surgery from fixing it, okay? So the surgeon's going to help decrease inflammation and help you if there's an infection, okay? So we still need to drain the bowel. We can't just say, oh, well, you just had surgery. We don't have to worry about your bowel for right now. We can't do that. The liver still needs to secrete the bowel so that we can live because we need some fats to make our protein, to make some of our tissues and enzymes and stuff. So we need those nutrients. And, so we need to be able to drain the bowel even after surgery. So that's why drain will be there. You want to check them out. If it's not draining, check for occlusion. Look at the patient. If there's jaundice, go tell the provider fast. Got the yellow, go tell, okay, check the color. You want to check for infection after surgery. Every surgery you want to check for infection, but definitely with the GI because you're dealing with an area that has a lot of bacteria anyway. So having surgery is very easy for colon content to be somewhere where it shouldn't. So you really want to watch for infection here with these disorders. So check for temperature, the purulent, drainage, fever, redness. You want to check for that. Trying a low-fat diet, liver not functioning. The liver is responsible for so metabolizing it. So intestines absorb it. It ships it in the blood where it absorbed, takes it to the liver for it to be metabolized. With that, to be used or to be put together like this catabolism and anabolism in the liver though. Make glycogen stores, make glucose, make growth hormone needed to. No, yeah, I think that's okay. Hold on. Okay, everything that you eat, whether it's fat, carbs, all of that is going to get turned into a sugar, glucose. Okay, some faster than others, some slower than others, but the end point is to create glucose for energy so that we can move. Okay, when we're low on energy, we're going to get hungry. Because every movement that we do, blink, it takes energy. So your liver is constantly working so that we don't just pass out or lose hope. All right, so we want a low-fat diet because the liver metabolizes all of our nutrients that we absorb. Okay, so that we can use them. Okay? These little codes throughout the protein. Protein going to get in the blood to keep the content in the blood. So protein like albumin is a protein. It is needed in the vessels to keep the fluid portion, the watery liquid, the stuff that wants to seep out. That protein is there to keep that inside of the vessels. So when we're having kidney problems, for instance, glomerular nephritis or nephrotic syndrome, protein is leaked into the urine, and when albumin, which is going to be decreased here, is gone, it's going to cause swelling. Okay, third spacing. The body can third space up to 6 liters of fluid. Okay, we only need 3 liters a day, but your body can put the fluids up to 6 liters in your peripheral, your legs, your lungs, around your heart, called pericarditis, pulmonary hypertension. Okay, so also what's so bad? Speaking of me saying that word, portal hypertension can happen here. If you do not get that fixed, let's say that bowels might build up jaundice. And if the liver can't metabolize stuff just getting stuck in the liver, that vein that the intestines use to get the food nutrients that it absorbed, only absorb it. It didn't metabolize anything. It just absorbed the food from your outside environment. And the liver is going to break it down to where your body can use it. The intestines is going to break it down to where the liver can do that. Okay, because the liver can't do what the intestines do. It can't break that piece down. So it's going to break it down to where the liver can use it. Those small little particles, pixels of the food is what the liver needs to make proteins, hormones, etc. Clotting factors. So if my liver ain't working because my gallbladder is inflamed, I can bleed. You want to watch for bleeding. Petechiae, those little small drops of blood are on like freckles. Watch for that. Definitely the angiomas. We're talking about the liver not functioning here because having cholecystitis can lead to liver problems if it keep happening. So no gas forming food, beans, cabbage, cauliflower, broccoli. You don't want nothing that's gonna cause gas. Okay, you want to avoid gas because your gallbladder is not secreting bile to break down fat. So more fat is able to go into the intestines. The bacteria in the gut try to break that fat down when that's not supposed to, and it creates a foul smell. So we want to decrease foods that's going to cause us to have gas, like eating fat. Okay? Well, you can't. That's what I told you. You want a low-fat diet for a reason. You don't have the organ to break that down. So our meds that we're going to use. So if I'm hurting, I want some opioids, maybe morphine. Okay? We talked about the bile acid. Going to use that to break down the cholesterol bile stones. Okay? So yeah, I thought.
Okay, the pancreas is responsible for releasing enzymes to break down fat. The gallbladder, excuse me, the pancreas releases enzymes to break down carbs and protein. The gallbladder secretes bile to break down fat. If the gallbladder isn't functioning right, fat is goes on to the small and large intestines, and they can't absorb fat. So you're going to have fat stool, fat deposits in your poo, and this would be a great indicator of if you're having some problems with your gallbladder and the biliary duct area.
So complications we talked about peritonitis, when that bowel goes down, to the peritoneum. So what do I look for if I have this? Oh no, my gallbladder just busted. What's going to happen? There's going to be a rigid, more like abdomen, because that thin shelf of membranous tissue is covering, like a protective covering to the organs. And if something is leaking inside of it, like it shouldn't, it's going to make it more puffy in that area, so you're going to have a rigid, like abdomen. That's the hallmark sign of peritonitis. Understand that this food is going all the way down, all over here. That food is leaking all the way up in here, okay? And when it's inflamed, okay, so the gallbladder is inflamed. White blood cells are going to be high. It's important to know that bacteria lives everywhere, and that's why we have our immune system to help get where bacteria is hiding at. Okay, so inflammation of your gallbladder can cause, like, it can be causing.
It's important to know that Gallbladder inflammation can be caused by other parameters other than stones. You can have a bacteria, trauma, um, a weakened immune system can cause, so.
Infection. Secondary to it bursting, okay? So my gallbladder has burst due to inflammation caused by gallstones hurting my wall line. Bacteria can get in there either way, whether it's bacteria that affect the liver. Bacteria can get in easily if the organ is injured and cause infection, which will cause inflammation too. So I'm trying. Having gallbladder inflammation is not only caused by gallstones. You can have a bacteria other than a stone that can cause your gallbladder to become inflamed. We're just talking about the most common cause of this, and that's gallstones. So that's what's going on. Like, okay, white blood cells are high, yeah, but if it's not a bacteria, it's not gonna be that high. Okay. All right. So borderline abdomen, talked about that. Abdominal distension, and that's the rigid like borderline is the same thing. Nausea, vomiting. This the gallstone. If it's pancreatitis can cause that duodenum area to become unscarred, and it can cause projectile vomiting. So a gastric outlet obstruction, pancreatitis can cause that. So if your gallstone is gallbladder inflammation caused by pancreatitis, it can also cause projectile vomiting. Okay, but you have to make it make sense. Talk about rebound 10 minutes hurts, tachycardia because when you're having pain, your systemic system is going to be up. So heart rate, blood pressure high, fever because there's inflammation. Okay, it's decreased in older adults. Okay, having peritonitis. Okay, so older adults having a fever can be decreased. They might be taking immunosuppressants. So fever, if you're trying to look for peritonitis in older adults, they might not have a high fever. So what you want to do if you see this, so you come in the room, see a patient, maybe holding on that side, it hurts, and then boom, it pops. All this stuff leaks into the bowel, all this out here, not supposed to be there. It's gonna cause an abdomen, like a puffy balloon. Like I just filled my abdomen up with some water. Right. You want to place them in a semi-Fowler's position like this, like a little bit up, gives them, ooh, this stuff hurts. It's gonna hurt. You want to monitor the respiratory status because peritonitis can cause sepsis. It's bacteria that's everywhere in large amount and quality. It's eating at a whole bunch of vessels. The bacteria likes to eat blood and tear the vessel wall. If our blood is leaking out into the peritoneal cavity, it's not getting to the lungs to get perfused with oxygen, so tissues are not being oxygenated or perfused. So we want to watch the respiratory status. If you breathe real fast, you know what I'm saying? You want to give oxygen to the person because this can happen. You can go to shock here. You want to turn the person into turn, cough, deep breathe. Get them to, we make sure their lungs is working because you can have that, but we still need the other organs, and to get those, we need our oxygen. We're going to maybe providing mechanical ventilation in peritonitis because, as we said, our blood is not circulating with the bacteria. It's eating the blood cell itself. That's going to cause anemia. If I don't have enough workers or red blood cells to go get the oxygen from the lungs due to them leaking or falling off the cliff because the bacteria ate the hole in it, it's going to decrease my oxygen consumption. Oxygen can cause tissue to die. We're going to need nasogastric suction to decompress the bowel, the stomach, get all that stuff out. We don't want nothing else irritating, nothing by mouth status to help with in case you want to vomit, too. You want a double lumen lube, too, when you're dealing with nasogastric suction, double lumen. NCLEX tip there. When you're having peritonitis, we want to rest the bowel, nothing by mouth, okay? We're going to give IV fluids. We're going to replace the fluid because we have to understand that bacteria is in large amounts, so it can do more damage faster than if it was just one itty bitty tiny bit. Just imagine someone opening your stomach up like a trunk, getting some poo out of the toilet, smacking it off in there, holding it back up. That bacteria is going to do more damage faster than it would if you just, let's say, you ate it off someone's hand, okay? So it's going to be eating at those vessels and your red blood cells fast. So we got all our blood content out. Also, it's being destroyed too. But as we said, that bacteria makes holes inside of your vessels and it leaks it out. So you get a risk for hypovolemic shock or hemorrhagic shock because you're hemorrhaging or losing your fluid. Okay? You're gonna need some oxygen when you're dealing with shock. Give antibiotics if it's caused by a bacteria. Okay, I'm sorry. You gotta make sure you're. I thought I'm like, why would we give? You have to hear it and make it fit. If it don't fit, it don't belong, and that's how this works. You would give antibiotics in peritonitis, okay? Peritonitis, you would give antibiotics because obviously bacterial content has entered a sterile area. That area is sterile, and that's why inflammation is big there, okay? So yes, the peritoneal fluid and cavity is sterile, so any seepage of anything that doesn't belong there is going to trigger a major response. Just like your lungs. Your lungs are sterile, so anytime there's something in there that's not supposed to be in there, that's why it's major coughing and you might have an anaphylactic reaction based with your lungs. You also want to monitor your fluid and electrolytes because you're going to be dealing with hypovolemic shock. Your vessel content is leaking inside of your body. It's not going where it's supposed to go. It's going to go into your tissues. You're going to be swollen. Just think about if a person dies, they look more bigger than they should because the organs are not making the protein nor keeping it. So whatever fluid they had left goes into their tissues and out of the vessels, third spacing. That's what I said. Okay. So that's why I want to monitor that, because if those holes are being made in my vessels, they're not being inside. Electrolytes going to be down. We need that for conduction of things. It's to maintain our water osmosis, sodium and water, having a relationship there. We want to monitor that. Because if I don't have fluids in my vessels, how can I pump all this blood around? Blood is like fish in water, and the water is what what electrolytes and fluid need is consistent of to help float those nutrients to different parts of the body, everywhere. Okay, so if they're gone, if I'm dehydrated, okay, which is what shock is going to be like. You're going to be dehydrated, no fluid in your vessels. How's that fish going to swim? How are those red blood cells going to swim? They're going to get easily sticky together, can clog up things, can cause a stroke. So we want to monitor those fluids because if they're gone, I'm trying to fix this initial primary problem. It can lead to secondary problems. Okay. So complications. Bleeding due to deterioration of the bowel. You want to observe for rectal bleeding because the gallbladder is going to secrete stuff. Okay, sorry, we're dealing with peritonitis. No other complications. Complications of the gallbladder. One is peritonitis. The second one is bleeding due to deterioration of the bowel because sorry. Okay, it seems like I had duplicated a slide too extra. So back to the complication of cholecystitis. We talked about peritonitis. Another complication is obstruction of the bile duct. If that gallbladder is inflamed, the swelling can obstruct that even more. And this can lead to ischemia. Once that tissue dies, it can't hold up like a rubber band anymore, so it bursts out. What's so bad about peritonitis? That bacteria can turn to gangrene. So remember that analogy of you seeing your trunk? If you keep it in there, you say, I'm not going to go to the doctor. I'm never going to the doctor because I've never seen a doctor in my life. And you let it stay there, it's going to rot inside of you. Okay, and this is going to cause peritonitis as well. If it hasn't, the stuff around it just started going further before it perforates. And then if it perforates, you got that plus its content inside the peritoneal cavity, and now you got major problems. Another one is bowel peritonitis. We talked about it perforating. Okay, if bowel is not draining properly, let's say you have a drain to drain out the content after surgery, and it's blocked, and it builds up, you can burst it like that. Okay. So you will still you can have surgery to remove the stone and not remove your gallbladder. So you can still have it in place after surgery. You want to make sure it's draining. Check for jaundice. This will let you know if the bowel is just clogging up. Post-cholecystectomy syndrome, and this is another complication. This is the symptoms that you had prior to surgery. You have it after surgery. If you have this, you need to report this to the provider because you still have the gallbladder, it's still inflamed. You need to go see to make sure that everything was done properly, or they didn't forget about you. I'm just kidding. So just remember that syndrome with this one. Okay, so that finishes up our gallbladder video. I will be back with my pancreatitis video. I hope you learned something. We're going to, from the lecture, sorry, it's not like I was about to, I had to remember, sorry. We're going to do some NCLEX questions, so I'm going to get that started. But a little overview breakdown. Gallbladder is used to store bowel. Bowel is used to break down our fat. The makeup of bowel consists of bilirubin, which is the byproduct of our red blood cells dying off. So the more dead cells that we have, the higher our bilirubin levels are. So if they are high or elevated, you want to check CBC blood levels, because this could indicate anemia if it's high. There's a lot of breakdowning of your dead cells, and why are they dying so fast? Why is it up so fast? So when red blood cells die, the body breaks down the dead content into bilirubin and a heme content. Bilirubin, when it's taken to the liver, this is unconjugated bilirubin now. Before it hits the liver, it's unconjugated. When it goes to the liver to be grouped together, it is now conjugated bilirubin. When it's stored also in the gallbladder, it is conjugated. It's together bilirubin versus unconjugated when it was going to the area of storage. So if gallbladder messed up due to gallstones, bowel clogs up, it invades the liver tissues. Liver can't do what it's supposed to do. That's why surgery is important. We're not going to go into the liver. We just basically cover the gallbladder. I also want y'all to check out these videos. If you're not understanding the content based off my words, a better visualization of it is key. So the guy I go to for that is my guy Armando, He draws his content on YouTube, and I'm going to show you a video of him for this lecture so that you can understand it. So we're going to go ahead and...
I was trying to point out that you want to watch for these complications here in all of your GI disorder complications. The most severe bleeding, inflammation that's going to cause bleeding, peritonitis is going to major bleeding. You can hemorrhage out. Fluid and electrolyte, you're not going to be able to with the liver being the gallbladder backs up, liver is not going to be able to break down protein or so that we can get our electrolytes the way we should. So it's important to know that that's bad if we're not getting that. Fistula formation. After so much injury, fistulas can form. Those cytokines dig tunnels and this can lead to infection of your poo is going into your vagina through these openings. So watch for UTIs with patients who have GI disorders like this. Toxic megacolon, very important. This is when unused bowel is just sitting in there and it's soaking up like a sponge. Eventually, it's going to get really big to where it's going to perforate, and we want to watch for abdominal distension here to code for this.
Answer 3 of our NCLEX questions. Okay, here's our first one. The nurse is caring for the client who is 6 hours post-open cholecystectomy, removal of the gallbladder. The client's drainage bag is empty. T2 drainage bag. What's draining it is empty. After surgery, that's a concern. And the nurse notes slight jaundice of the sclera. So he just has so this would be that syndrome that I told you about, post-cholecystectomy syndrome. And this is what you want to check for and notify the provider because you're not draining the gallbladder. All right. And the nurse notes slight jaundice of the sclera. The action by the nurse is most important. So it's third up again. Which action by the nurse is most important? Is it 1, reposition the client to remote T2 drainage? It doesn't tell me if there's occlusion or nothing like that. It's not saying he's laying on it. And surely it won't be like the after surgery. 2, to telephone the surgeon to report these findings.
I apologize for that. So the question is, the nurse is caring for the client who was 6 hours post-open cholecystectomy, the removal of the gallbladder. The client's T-tube drainage bag is empty, so that drain, okay, why is it empty after surgery? That's not good. And the nurse notes slight jaundice of the sclera. So any kind of yellowing discoloration of the skin and eyes is the indicator that my liver is not working right or something's causing that. Okay, so which action by the nurse is most important? Okay, so if I got jaundice, what's important? I can't do anything. As a nurse, we can't do anything without an order. Know your scope of practice. So 1, reposition the client to remote T-tube drainage. It didn't say anything about him it being occluded or him laying on it or something like that. You got to read your scenario well. Telephone the surgeon to report these findings. I like that because it's jaundice. What's so bad about here? If I have jaundice, my liver is not working, what is building up that can cause comatose and death? Ammonia. Let's explain that order. We eat our food, small intestines break down proteins. The liver takes that absorb those absorbed nutrients and stores it, builds things, and transforms toxins into non-toxic so that we can get it out. If protein is turned into ammonia from the byproduct of being broke down, the liver takes that ammonia and turns it into urea, where the kidneys secrete it as urine. If my liver's messed up, ammonia is not being turned into urea, so ammonia is building up. This can damage your brain. Okay, you're going to have LOC changes here and flapping of your hands. So this is a medical emergency because you can die from here. This is toxic, okay? So we're going to telephone the surgeon to immediately fix this because we only got a certain amount of time before this ammonia level builds up and kills my patient. So let's talk about 3. Ask to CNA for, these are CNAs. ENA is the same thing as CNA, okay? To obtain a blood pressure. That's not going to do anything for me in this situation, okay? Record, it'll tell me something, but we already know that it's the complication. He's having jaundice due to the gallbladder not being draining. It's not draining, okay? Maybe the surgeon messed something up. I'm not saying, or something. Okay, remember that symptom of you having the same symptoms as you did before surgery. This is what this is, and you want to report this to the provider. Okay, record the findings and continue to monitor the client. Okay, not going to continue to monitor because obviously something's going wrong. Now back to the syndrome post. Let's go back to the slide, and I'm going to show you what that syndrome is. That post-cholecystectomy syndrome. It's the same things that you had before you had surgery, and we're going to report that. So,
answer 3, ask the CNA to obtain a blood pressure. Why? record the findings and continue to monitor. There's a complication already happening, so I'm going to telephone the doctor. Why is it so bad? Because jaundice is indicating that you are closer and closer to the ammonia buildup. Ammonia buildup can cause coma and death. Why is this? The liver breaks down protein. The byproduct of that protein being broken down is ammonia. Ammonia is converted into urea in the liver, and the kidneys secrete urea out in the urine. So if my liver is clogged up, I can't transform this toxic chemical that wants to destroy my organs, tissues, like ammonia. Without the liver, okay? Without the liver, this ammonia is going to destroy things. So if my liver is clogged up with bile, can't drain it, it's impaired. It's going to get, so it can't do that. So ammonia builds up and leads to the flapping of the hands. Remember that. And we'll talk about that when we talk about our cirrhosis lecture. So I'm going to telephone the surgeon because I do not want these ammonia levels to be built up. Okay. Our next one is here. Okay. Excuse me. We're at okay. The nurse has been assigned to care for 4 clients. Which client should the nurse plan to assess first? Is it 1, the 50-year-old client who has chronic pancreatitis and is reporting pain level 6 out of 10 on a mineral scale? Okay, let's assess the other ones because pain is a priority.
Okay, I'm going to give y'all time to read this. The nurse has been assigned to care for 4 clients. Which client should the nurse plan to assess first? Okay.
2, the 47-year-old client with esophageal varices who has influenza and has been coughing for the last, I do not like the way this sounds. Varices are those very fragile veins, and when you're coughing, you can irritate them and they can burst and cause hemorrhagic shock and death, okay? And their coughing, these vessels are inside of your esophagus. When due to portal hypertension, like with cirrhosis, that blood backs up, and it's a lot of blood, so it doesn't have anywhere to go. So it makes the vessels larger than what they should. I'm talking about really big vessels filled with blood, and they're fragile, and they can easily burst. So coughing for 30 minutes, and you have this, is a big concern, okay? So let's look at the other one. The 60-year-old client who had an open cholecystectomy 15 hours ago and has been stable through the night. Well, there's something concern here. 4, the 54-year-old client with cirrhosis and jaundice who is reported having itching all over the body. This is a concern too, but due to airway breathing and circulation, hold on. My options are stuck between 2 and 4, so we got to narrow it down. The 50-year-old client with cirrhosis and jaundice. So it's expected for him to have jaundice and cirrhosis. So I'm going to go with 2 because this is a major concern.
Okay, an NCLEX tip. If you have a question like this that has a disorder, you have to know the symptoms with that disorder, because if it's normal for it to be associated with that, it's not a concern. Okay, so don't get tricked up like how we almost just did. If they got jaundice, of course they're going to be itchy because the yellow in the skin there, they're going to be itchy. So it's not really a concern because why? They have cirrhosis. That's a symptom of cirrhosis. Jaundice, your liver is not working, period. So our answer is going to be 2 with the varices. These are very fragile veins that can easily burst and cause hemorrhage and shock and death. And if this person, due to portal hypertension, that blood builds up into those vessels of the stomach and the esophagus, okay? So if my patient is coughing, it's going to be rubbing against those vessels, and it can cause it to rupture. And so this is this is what we're going to talk. Give her some cough medicine or something. We don't want her coughing. It can burst those veins, okay? Oops.
So my answer is 2. We're going to check it too. So hold on, got 1 more to go. All right. The nurse is caring for the client with acute cholecystitis. The nurse anticipates that conservative treatment will include which component? So conservative means I'm going to conserve what I have left. How am I going to do that? I want to rest that area. How am I going to rest it? Let's look at it.
Okay, I'm going to read that to you. The nurse is caring for the client with acute cholecystitis. The nurse anticipates that conservative treatment will include which component? We're going to save it. Okay. 1, providing a low-texture bland diet. 2, giving anticholinergic medications. 3, positioning so the head of the bed is flat. 4, administering laxatives to clear the bowel. So how we're going to conserve the function of our organ that's hurting after we treated it? How are we going to conserve that?
Number 1, providing a low-texture bland diet. That might, but it might. Low fat, Okay, let's see. It didn't say low fat, it said low texture. So let's look at the other ones. Giving anticholinergic.
Another thing with NCLEX answering, if it didn't say it, don't assume it's saying it, okay? You take that question for what it's written on the paper and saying, okay? Like, you see how I tried to say low. We know we want a low-fat diet when it comes to gallbladder problem. So it says low texture. It didn't say low fat, okay? Watch that stuff now.
I like that because when fat is inside the duodenum, it causes the gallbladder to spasm. So we want something to help prevent that when it's trying to heal, because we're trying to heal it's inflamed. 3, positioning so the head of the bed is flat. That's not going to do anything. And menstrual dialysis, we do not want this. So the answer is 2 for me. So now we're going to check. Okay, so I'm going to go ahead and, excuse me, push this over a little bit more. All right, so if you got all 2s like I did, woohoo, that's good. That was not to take like that. I'm trying to build my knowledge to where it's easy for me the way I'm trying to help it to you as well. So me getting it right is an excitement moment for me too. So, I mean, yeah. So we got it right, good. Thank you for participating in this presentation.
So if you're needing the rationale, I have that here. I already explained those rationales as we were answering the questions, but here is it just so that you can read it for yourself as well. I appreciate your visitation and my lecture. I hope you learned something, and there's more to be posted. Thank you.